Very good afternoon. Thank you for the kind introduction, Mr. Chairperson. Um, I'm here today to talk to you all about BPSD, which is behavioral and psychological symptoms in dementia. And I would like to focus on the assessment of it. Now, what is BPSD? BPSD refers to the behavioral and psychological symptoms of dementia. It's extremely common. Okay, it has been defined by the International Psychogeriatric Association as neuropsychiatric symptoms of dementia, characterized by disturbed perception, thought content, mood, and behavior, frequently seen occurring in patients with dementia. Now, this can be present in up to 98% of people who suffer with dementia, and it's almost 100%. It's quite alarming. And up to 84% of people with dementia have at least one clinically significant PPSD, and this can range from agitation, irritability, psychosis, sleep disturbances, and also wandering behavior. Now, there are few factors that affect PPSD, and these can be divided into disease duration, increasing age, education level, population, and severity of cognitive impairment. Certainly influences the prevalence of PPSD. And what we find is that with worsening dementia, we also get worsening of the patient's PPSD. Now, there are various types of PPSD organized into various different clusters. I'd just like to give you a brief overview of them. I'm sure the other speakers would have spoken about it earlier on. Now, the most common type of BPSD, and we oftentimes see in Alzheimer's disease, is actually apathy, and this really reflects the lack of motivation that is seen in patients with dementia. Okay, the other common BPSDs that we see are agitation, irritability, anxiety, the presence of psychotic symptoms, most especially delusions, and they are very specific delusions for people with dementia, and this can be classified as persecutory delusions, delusions of reference, and also misidentification syndromes. For example, phantom border syndrome, and also Capgras and Frigoli syndromes. Okay, people with dementia oftentimes also develop mood disorders. They develop depression, anxiety. They may become disinhibited and thereby mimic someone with bipolar mania. Okay, they may become euphoric. They may lose sleep, have changes in their sleep pattern, and also have stereotyped behaviors. For example, wandering behavior, rummaging, or picking. Now, the first thing to do when we are assessing patients with dementia is really, the first thing to do when we are assessing the presence of PPSD in someone with dementia is to really rule out delirium. Okay, and when we're talking about delirium, it's useful to use the confusion assessment method scale, also known as the CAM scale, and we're looking really at acute onset of illness and whether there is any fluctuating cause. Okay, we're looking for the presence of inattention. We're looking for the presence of disorganized thinking characterized by disorganized speech, and also at the also looking for altered level of consciousness. And to diagnose delirium, you need to have 1 and 2 plus 3 or 4. Okay, so I find this to be a useful scale, can be used at the bedside to diagnose delirium. Of course, with the presence of delirium, you will be less likely to diagnose PPSD. Okay, so once the delirium resolves, the patient oftentimes ceases their problematic behavior. Okay. We also need to consider pain. Now, in the community, more than 50% of people with dementia suffer from pain. And in those staying in nursing homes, this figure really goes up to 80%. Now, there are various causes of pain in people living with dementia, and these pains can be categorized into musculoskeletal pain, gastrointestinal pain, for example, gastritis, peptic ulcers. UTI is extremely common as well, especially amongst female older persons, and this is quite often a trigger for the development of PTSD. Oftentimes they are wounds. Okay, they could have obvious wounds or even more occult wounds. Sometimes they have sacral sores that have not been detected, and this very often exacerbates the onset of BPSD or the presentation of BPSD. And of course, underlying cardiac conditions that can give rise to nociceptive pain. Now, how do you assess pain? There are various pain scales that we use in the assessment of dementia. I can give you a few examples. First one is the discomfort indicator scale. The other one is the FLAC scale. And the other one is the pain AD scale. I'll just show you a brief example of this. The pain AD scale is used for pain assessment in advanced dementia. So in patients who are not really able to vocalize and to talk. So you can't ask them, for example, you can't ask the question, are you in pain? Can you explain to me how intense the pain is? So for patients with advanced dementia, we're looking really at 5 domains. Okay, we're looking at their breathing, we're looking at their vocalization, we're looking at facial expression, body language, and how consolable they are. And you can look at the scoring over there. Okay, and this gives you a picture of how severe the pain is. Obviously, higher scores indicate more pain. The face, legs, activity, cry, and consolability scale, also known as the FLAG scale, is a scale that we use in the pediatric population, but also can be extrapolated for use in the older person population as well. Okay, and again, here we are not relying on their verbal output, but relying more on our mental state examination. And this is also very suitable for use in patients who can't really verbalize their pain. Now, for those of you who find mnemonics quite useful, I find this particular mnemonics to be useful to be used as an assessment tool for patients who suffer from BPSD. The first one, so this mnemonic is known as the pieces mnemonic. Okay, the first alphabet P actually refers to the physical causes of behavior. So if a patient is very agitated, for example, shouting and screaming, is there an obvious physical cause for the behavior? Is the patient in pain? Is the patient having a wound that has not been treated before? Is the patient having any obvious precipitant for his behavior? Okay, so rule that out. The second one is I, intellectual behaviors. We're really looking at the various causes of the patient's lack of intellectual capacity in the patient's dementia. For example, we're looking for the presence of agnosia. We're looking at the presence of apraxia, amnesia, and also anosognosia, which is the lack of insight. So the presence of all these A's really will worsen the presentation of PPSDs. Okay. The next factor we're looking at is emotional causes. We really want to understand whether the patient is upset about something. Is the patient grieving a loss of a loved one? Is the patient depressed? Is the patient angry because, for example, the food has been stolen by someone else? Okay, so we really want to ask and inquire this from our patients with dementia. The next factor is the caregiver factor. Sometimes caregiver distress and burnout can really directly affect the patient's PPSDs. I oftentimes find when caregivers are feeling very stressed, they displace their anger and they displace their frustration onto their loved ones who suffer from dementia. And what happens is that these people actually develop worsening of their behavioral symptoms. So if they're not able to sleep before this, they don't sleep at all. If they were having psychotic symptoms, the psychotic symptoms become even more entrenched. So we really need to treat our caregivers first to adequately treat people with dementia who have PPSD. Okay, the next factor is the environment. How is the patient's environment? Is there anything in the environment that's irritating the patient? Is the environment too bright, too noisy, or is it too quiet? Is it too dark? So really modulating the sensory input to the patients through the environment is going to be very important. The last domain or the last factor is social activity. Is the patient getting adequate social engagement? So oftentimes, for example, in an institution setting, patients are not getting enough social engagement. They are oftentimes just left to be alone. They are wandering and pacing alone at home. They're just put in front of the TV, they're not getting enough interaction to stimulate their mind. And studies have shown that a lack of social activity is also associated with worsening BPSDs. Okay? So this is a brief tool that can be used. Now, very briefly, before I end, I'd just like to talk to you all about the three models of behavior that can explain BPSD. The first one is unmet need. Okay, so BPSD can be explained through this model whereby patients present with this problematic behavior because they are trying to verbalize or vocalize an unmet need to their caregiver. So it could be that they are in pain, they are hungry, they are cold, they are not getting the food that they need, or they just have an unmet need which is not being met by the caregiver. The second model is known as the learning model, whereby we're really investigating the relationship between antecedent behavior, for example, triggering event, the behavior itself, and also consequence to that behavior, also known as the ABC model, antecedent behavior and consequence. So I give you a brief example. If a patient is oftentimes wandering out of the house, and walking onto the main road, what are the antecedents to that behavior? What are the triggering events? It could be because the gate is left open, or there's lack of manpower supervising the patient at the home, which is why the patient finds it quite easy to go away. Or it could be because the patient is responding to an old memory. The patient thinks that her husband that died many years ago is outside of the gate and asking the patient to come in. So understanding this is really important. And then we come to the behavior itself. What is the nature of the behavior? The patient opens the gate and walks out of the gate and walks into the main street. And what are the consequences of that behavior? So what actions have been taken by the caregivers to address that behavior? Has the caregivers gone through with the patient the entire flow of the event, or has the caregivers gotten angry with the patient and tried to sort of forcefully drag the patient out into the house and restrain the patient without even exploring why the patient did that in the first place? So if there is a negative response to the patient's behavior, the patient is more likely to repeat that very problematic behavior. But if you were to take a root cause analysis model of the behavior and try and understand the genesis of that behavior, patients are less likely to repeat those problematic behavior over time. The third model focuses on the stress threshold that the patients have, and we understand dementia as an illness, and as a result, patients really have greater vulnerability to exhibit problematic behavior because their brains are not able to process the various different stimuli that is presented to them. Okay, so these are the three various different models in a nutshell to explain the genesis of PTSD. Now, this is my last slide, just to give you all an overall assessment of PTSD. The first thing we do is to obtain a full history, including a medical and psychiatric histories. We want to know what kind of medications they're on as well, what were their pre-morbid personality and cognition and their state of functioning. Always do a full physical examination. Oftentimes, just by observation, we can find wounds, we can look for sacral sores, we can look for obvious precipitants for the patient's behavior. We need to order important investigations that will include a full blood panel, infectious disease panel if necessary, and also do a urine test as well to rule out a UTI. We may do a standardized rating scale, but these are usually done in a research setting. But you could perform the neuropsychiatric inventory or the Behave AD scale to help you quantify the extent of the patient's PTSD. If the patient is having any underlying medical condition, please treat this condition first. For example, concurrent pneumonia or a UTI. Okay, you need to remove offending drugs. For example, anticholinergics and benzodiazepines. These two are the evils of geriatrics. Okay, I don't like prescribing these medications because it really causes all kinds of complications. It causes confusion, increases the risk of fall, and worsens PTSD as well. Okay, so once you've done all this, you can eventually confirm the diagnosis of PTSD and approach the patients well. With that, I'd like to end my presentation for today. Please feel free to ask if you have any questions. Thank you very much.